All righty. So today, I have the pleasure of being with Dr. Robert Talac today. And today we're going to be exploring something that is very interesting. Not a lot of physicians, clinicians, researchers, you know, talk about this. And I believe it's something that is very important to discuss. So does Dr. Talac. And that's why we're here today. And today we're exploring one of the most puzzling questions in modern regenerative medicine or medicine. And one of the questions is, why does regenerative medicine sometimes produce remarkable results in some patients while others doesn't nothing happens at all, right? To others. And two patients can receive the same exact treatment, the same biologic therapy, the same procedure by the same physician, but nothing changes. And for years, this inconsistency has been one of the biggest challenges facing regenerative medicine. Is the problem the therapy? Is it the patient variability? What is the problem, right? And today we're going to be going deeper about how regeneration actually works. And today I'm here with Dr. Robert Talac. He is an orthopedic surgeon with more than 30 years of clinical experience and the author of the Regenerative Intelligence book series. Dr. Talac has spent most of his career studying why biological therapies succeed in some cases but fail in others, and what that reveals about how the body actually heals. Dr. Talac, thank you for joining us. How are you today?
Thank you very much, Oscar. I hope I will not disappoint. Yes.
No, not at all. You're definitely not going to disappoint us here. We're going to be going through a lot of questions, and we're going to make the audience think today, like really think outside the box. And so the title of today's podcast, just for all of you guys watching, we have, this is a episode one. We are going to have a second and a third series to this podcast, and they all add to each other. So after you watch this one, come back to the other one and just kind of look at our LinkedIn, our YouTube channel, and to look for all the recurring series that it's coming in. So, Dr. Talac, you spent more than 3 decades participating in orthopedic and spine surgery. What made you step back and begin questioning the entire model you were originally trained in? You were
Well,
trained in. Apologize for that.
I understand. I understand. Well, Oscar, this is a very good question, and answer did not come suddenly to me. It emerged gradually over many years of my clinical experience. I was trained in traditional orthopedic model, and that model see musculoskeletal problems primarily as a mechanical failures of structure. So in that framework, if the structure is damaged, the logical solution is to repair or replace it, you know. So for many conditions that we approach, it works very well. Surgery can be pretty remarkably effective when structure instability or severe damage is present. However, over maybe last 20 years, I began to notice something that it did not really fit into this model. I saw many of my patients, they had imaging studies show significant structural abnormalities, but they have very little pain or functional problems. At the same time, I treated many patients with relatively small structural problems, but they have severe symptoms. So this observation made me step back and start asking questions like, perhaps problem was not always structure itself. Perhaps biological system in which that structure existed is the primary problem. And, you know, we all understand human body is not simply a collection of parts. It is adaptive biological system and in which movement, metabolism, immune signaling, neural regulation, all these processes interact continuously. So if these systems remain coordinated, tissue often maintain their resilience, even if there is some structural problem. But when this coordination is disrupted, dysfunction may emerge, and even when anatomy appears to be intact. So this realization gradually led me to explore different perspectives. So I turned what I call turn to dark side. And I have eventually described this as a regenerative intelligence. It is an idea that healing is not something the physician create through intervention and all, although I am a surgeon and I thought that interventions are important. But I believe that healing is the process where the organism perform what the biologic condition allow them. Okay. So from this perspective, I believe that role of medicine, especially regenerative medicine, change slightly. If we are trying only correct structure, we should really start with a restoration of environment in which that body can heal. So in my view, forcing body to change is not really a right way. And I believe that understanding biological intelligence is one of the things which is really the right direction in the future of the medicine.
You mentioned a couple of times biological systems, and then you just mentioned biological intelligence. What is that? And then what's the difference between biological system and intelligence?
Well, these are what I mean by these two words is that we have different systems: immunology, metabolism, neural system, movement. These are systems. And biology, these are interconnected systems with a lot of processes that work together. And if you have those processes really well aligned, then body is tremendously smart to be resilient and respond to anything what it encounters. But if you have those systems are not uh, in alignment, I sometimes use word coherence, then everything changes.
Yeah. Would you say also alignment? Would you say also like homeostasis is a good word to say or no?
Yes, but homeostasis is usually we look at homeostasis like on level of chemical metabolism. This is this is a little bit beyond because we need to look at beyond metabolism. This is biologically speaking, these are different tissue are coordinating among themselves, like immune signaling, cellular metabolism, mechanical forces. It's all observed by neural regulation. So these processes are continuously operating within organism. So body already possesses capacity to repair and adapt. So when I start looking at the patient, I don't start with a syringe. I start asking whether the condition exists that allows those processes to unfold or not.
So, in the series and the books that you've written, you've mentioned that regenerative medicine does not fail first in the clinic. It fails earlier. You just touched upon that in language, right? What do you mean by that?
Well, when I say that regenerative medicine often fails first in language, what I mean that we frequently misunderstand how regeneration actually is before we begin even applying it clinically. The words we use shape how we think about biologic processes. So if you ever listen to doctors or our conversation, the regeneration is often described almost as if it is a product, something we deliver to body through particular therapy or technology. You probably hear a lot of us speak, we are regenerating cartilage, we are regenerating disc, or we are regenerating any tissue, as though the intervention itself performs the regeneration. But biologically speaking, that's not how regeneration works. As I was telling you, that living tissues regenerate through complex coordination between multiple systems. I mentioned immune, cellular metabolism. So when your language suggests that regeneration is something we apply to body, I believe we unintentionally adopt mechanical mindset. We begin to think treatment as if there are tools directly rebuilding tissues, much like when you repair the machine. And I don't think that's a reality because most regenerative therapies do not rebuild tissue directly. What they do introduce are signals or you can think biological cues that interact with organism own mechanisms. And I truly believe that this distinction, although seemingly subtle, is extremely important, because if we misunderstand regeneration as a procedure rather than biological process, you are now setting yourself up with different expectation. Treatment strategies become misaligned how the living system exactly behaves. So that's why I am, I am concerned about language we actually use. And that's why I wrote in my first book in the series, it's called Regenerative Intelligence Lexicon. That's where I explore how terminology we use influences our thinking, our research question, and ultimately clinical decision. So if you think that somebody was labeled as a degenerative, that have degenerative condition, or we say the patient is a failure, that's all setting up how we start thinking about it. So I believe that the regenerative therapy is, or outcome is determined by language first, how we talk about it. So
Yes.
that's why I use that term.
Yeah. How much do you think is actual marketing driving that, mislabeling, or, or not using appropriate scientific terminology?
Well, there is certainly plasticity, and marketing is fine, but we have this inconsistency even among physicians. Sometimes that was one of the reasons I wrote the book, because I teach quite a bit, and when I use some of the terms, people say, "Oh, I understand what you mean. I understand." And then when we go a little bit deeper in the conversation, I realize, no, we are using same language, but we are world apart. So I believe that marketing is part of it. We are a little bit lazy with the language. And then we are also trained with a old paradigm, which is literally traditional medicine think the body is the machine and we fix it. A long time ago, I used to refer to myself jokingly that I'm glorified carpenter.
I mean, yeah, why not? I think that's a
I
great idea.
we used to screw people and mechanically fix stuff. So I don't do these anymore and start looking at it a different way. But yeah, I think that this marketing may have some, but we need to be more precise
Yeah.
with our words
Yeah. Of
because they matter.
course. I agree with you 100%. So, when people think of regenerative medicine, everyone thinks about stem cells or PRP. Okay. Um, but you argue that this is actually the wrong starting point. So, what is regenerative intelligence to you? What does that mean?
Okay. Well, Oscar, it's understandable that most people associate these regenerative medicine with specific technology, stem cell, platelets, biologics, fat
Exosomes.
drive, and then exosome, you name it. Those tools have received quite a great deal of attention, and in certain circumstances, I believe they can be useful. But I believe they are not starting point. And reason is that starting point is understanding how living systems actually repair themselves. Again, as I said, that biological regeneration is not something that occur because Robert Talac decided that he will inject some particular substance into tissue and body will just follow. The regeneration emerges from these coordinating activities of multiple systems. Again, I was telling you, immune signaling regulates inflammation. Cellular metabolism provides energy required for tissue adaptation. Nervous system re- just influences protection and movement pattern, especially in musculoskeletal system where I practice. If you have mechanical forces that are applied to tissue, they are not correct. The body is not going to respond. So, as I was telling you, that when these systems are aligned, the body possesses remarkable capacity for adaptation and recovery. And this is the idea behind what I describe regenerative intelligence. It just It is a simple recognition that organism itself contains intrinsic biological intelligence. a set of processes that guide repair, adaptation, and resilience. So, from this perspective, regenerative therapies are best understood, in my opinion, as the signals introduced into the system rather than standalone solutions. And I also believe that their effectiveness depends greatly on biological environment in which they are applied to, not as a standalone. So the focus, in my opinion, should shift. Instead of asking which therapy to use, we should start asking more fundamental question. And I mean that what condition allow organism regenerative processes to function effectively? And then from this point, regenerative intelligence is just simply attempt to understand and support those conditions.
Interesting. There's a lot to unpack there, and I have so many questions. When you talk about the environment, are you talking about obviously, the patient, if they're smokers, then that's not a good environment, right? So is that kind of the environment that you're
Yes,
talking about?
yes, that's a smoking, metabolic part, inflammation. There are
Yes.
multiple layers. So in other words, we have to take, I think in the principle, we all are focusing on biologics, what I call signal. But if you are providing signal into human body, which is from system perspective, adaptable biological system, the, that body will receive the signal and then decide whether it is in the body's best interest to respond. And if we are ignoring body and we think that because I inject stem cells, it will automatically heal, we will be very disappointed. And I think that's what comes to the topic of today's discussion. Why some people respond, some people don't, despite the fact that we have same therapeutics, same procedures, everything, because we just have ignored the second half of the equation.
Interesting. So for some, I have one question. So for someone that's starting out, a doctor that's starting off in regenerative medicine, and obviously the first thing when they think about regenerative medicine, they think about stem cells, PRP, exosomes. But you're saying that that's not the starting point. Where should they start?
Probably, I think that they should do quite a bit of introspection because it's not easy to transfer and it's not overnight change. Okay. What I mean by that is first question I would ask, should I be a physician, is um, do I really want change how I do and practice medicine? Because you will now have a lot of questions. The system is set up completely differently. There might be monetary consequences. Your colleagues will feel that you might attack them by really starting asking tough questions. You might be ostracized. Some people can be reported. You will, what I call, you will have to face your demons. And, but I would not change my practice, but I would first start thinking about myself, start talking to people, and I would explore how am I going to go about this change. This is not something, and I see this very often that people use regenerative medicine as a marketing stunt. It's like, oh, we use now regeneration and give me a protocol and let's inject. This is not regenerative medicine. If you embark on this with this approach, you will have really hard time because patients will not understand why they don't respond. And the second layer is you cannot do it all alone as a physician. The patient needs to collaborate with you because what you do is important, but what they do at home, sleeping, eating, inflammation, stress management, that will also affect your outcome. So
Yeah.
I always ask patients in my clinic, are you willing and able to work with me? And if they are not able to, you have to start rethinking whole process.
Yeah.
Starting is not taking textbook, really in retrospect, to look, do some soul searching. Is this is good time? What are the consequences? And quite frankly, if somebody who is listening to this has would like to just shoot me an email, I would love to do so. I have basically changed from spine surgery, which is pretty lucrative and pretty technically specific field. Since 2019, I do exclusively regenerative orthopedic spine care. Just for a little bit for those who are like in the previous medicine, I used to see 6,000 patients and do 700 surgeries a year. Now I do barely 20. I spend three times more, that's three times long lengthwise with my patients. It is completely different. Many times I've been questioned, am I still surgeon because I do only 20 surgeries? Because patients don't want a surgery, they heal without it. Did I abandon what I have been years studying? So there are a lot of questions. I call them demons. I'll be happy to help anybody if this is a whole topic,
Yeah.
uh, maybe a different podcast.
Yeah. It sounds to me which it's a mindset shift for the doctors, right? Because I mean, I didn't go to med school, but I would imagine that that's not taught in med school to think
No,
like that, right? And so imagine they've gone, I mean, depending on, the residency and they've gone what, 8 years, sometimes 12 years more of a specific journey. And now having to switch that mindset can be very challenging.
it is challenging because we are very parochial physicians. So you have 4 years of college, 4 years of medical school. You have 5, 6 years at least in orthopedics. You have 5 to 6 years residency. I went to do 2 fellowships, and then I did also my PhD in biophysics. So yes, it is a lot of work and a lot of training and sometimes even indoctrination. And then you suddenly change. When I start talking to my colleagues about metabolism and inflammation and looking at sleep and stuff, they look at me sometimes, you got really have problems. But I think that this is why regenerative medicine challenges this, what I call traditional procedure centered mindset. It reminds us that healing is ultimately a system phenomenon. And we as a physicians are not here to only apply treatments, but help to restore this biological condition in which body-owned regenerative processes can function effectively. And that's
Well,
completely different mindset.
nicely put. I wanted to touch on something that you mentioned, kind of like unlearning indoctrination. So like I've realized even for my personal career growth that unlearning whatever you thought was truth or what you learned is a great skill to have, like unlearn, right? It's a great skill. Sometimes you have to unlearn and start from scratch and provide that mindset.
Yeah, it is difficult, but
Yeah.
it's not unachievable goal. It just when you have my grandmother used to say, "Tell me why, and I'll tell you how." And I think that if for myself, I treat quite a bit of high-end athletes, and my own son has been one of them. And I started using, I started 30 years ago in tissue engineering and spent a lot of time you know, in the lab 4 years. Just I put my clinical career kind of on a hold because I really want to understand how these things works and stuff. So that was a lot of time and effort. And now I use natural biomaterials, do in-situ regeneration, use personally PRF, and which stands for platelet rich fibrin. And but this is not about injection. This is only a signal. I spent last 10 years trying to understand body signals. One of them is to talk to patient. That was my first change. Surgeons don't talk. They used to just 3 minutes, you need surgery off. So yes, it is. It is not easy, but it's not an achievable goal.
Yeah. Thank you for unpacking that. So, one question is that I have so why does the exact same regenerative procedure produce a remarkable result in one patient and then almost no effect in the other? So, I know you briefly touched upon it, but think we can expand on that a little bit more.
Okay, okay. Uh, Look, this was actually one of the questions I start thinking more deeply about regenerative medicine in the first place. So again, as I kind of alluded, in traditional medical training, we are taught that if the treatment works, it should work fairly predictable across all the patients. And if the same procedure, standard care, is performed correctly, we should expect similar outcomes. That's the traditional thought process. But biology rarely behaves that way. The reason the same procedure can produce remarkable results in one patient and very little effect in another is that procedure itself is only one part of the larger biological system. I truly believe that what ultimately determines the outcome is not the intervention, but that environment in which the intervention is introduced. And this is one of the problem I have with clinical studies and all this stuff. Every patient arrives with different physiological landscape. You can imagine their immune system may be balanced or chronically inflamed. They can have cellular energy metabolism that is robust, or they can be compromised. How about movement? Let's say their movement distribute mechanical forces efficiently, or they are putting abnormal stresses on tissue that we are trying to help to recover. So all these factors influence how the organism will respond to regenerative signal. So if I use, let's say, platelet-rich plasma or PRF or any other biological therapy, we should look at those. These are not direct builders of tissue. It's better to understand it as a signal that interacts with body existing repair mechanism. So if underlying biological system is coordinated, as I told you,
Mhm.
signal may trigger cascade of regenerative activity, you have excellent outcome. But if environment is unfavorable, for example, you have dysregulated inflammation, or you have energy available for cell adaptation is limited, or you have really bad coordination, mechanical forces remain dysfunctional. Same signal, same sophisticated injection may produce very little visible effect. So in other words, I believe that regenerative outcome depends less on intervention alone, but more on a state of organism receiving it. And this is, I believe, why regenerative medicine is different. And that's what I told you. We are not here, we are not technicians. We are not me mongo, me fix. We are physician, maybe healers, and we should first and foremost restore biological condition and understand it. And then we can apply the signal to manipulate it in a way that so the body can positively or effectively respond.
Yes. So, is this so you said signals, signals, signals. With Dr. Kaplan, does that correlate with how he originally mentioned mesenchymal stem cells and then he switched the term to medicinal signaling cells?
This is one of the most fascinating story in regenerative medicine, the story of mesenchymal stem cells. I sometimes call them mesenchymal stem cell myth because mesenchymal stem cells has been discovered by Frenstein, if I'm messing his name, in 1960s, and then in 1990s, Dr. Caplan identified mesenchymal cells in bone marrow, which were able to attach to petri dish, and yes, in vitro, with application of what we call growth factor cocktail, they were differentiating into different tissues, muscles, cartilage, bones. So this mesenchymal stem cell hypothesis has been formulated, and Dr. Kaplan coined the term mesenchymal stem cells. This was very interesting idea because if it is true that there are cells that can be transplanted into damaged tissue and those cells will transfer into cartilage bones, we could just transplant those cells mechanically and everything will be nice. And thousands of papers has been published and everybody is today believe that that's how the body works. Unfortunately, in 2010, Dr. Caplan, and others start observing that those cells, when we did in vitro labeling studies, in vivo, forgive me, we find out that those cells have very little lifespan. They do not differentiate in the targeted tissue. They actually die. But we also observe that there is some effect on patients. So the question logically came out, what is it they do? And then Dr. Kaplan and others changed MSCs. I call them, they rebaptized them. So they now call the mesenchymal signaling cells. So we believe that it is through paracrine signaling effect, they actually collaborate with the local regenerative processes. So now MSCs are not mesenchymal stem cell, but medicinal signaling cells. When I will finish with this is a whole different topic. In 2022, Dr. Kaplan received Life Achieving Award for life on, I believe it was in World Congress of Regeneration. And his topic or title of his keynote was, "There are no stem cells in adults. There are no stem cell therapies. Can you hear me now?"
That's bold.
It's a father of mesenchymal stem cells. So research is evolving, and I think we are understanding now that those biologics are more signals than really drugs. And we need to now focus on environment that is receiving it.
You know, you mentioned something that kind of popped up in my head. You said that these injections or, they're not drugs. That's a good, the reason why it just popped is because I wonder because if they're not drugs, would that mean that they should be categorized or regulated differently by the FDA? It was just a question that just popped, right? Because obviously, when the 351, the drugs, and if you're mixing it, minimally manipulated. If you're mixing with things, then it makes it a drug. So like that just popped in my head. I wonder if
It
it'll
is,
change the
is
regulation
yes,
landscape.
it is interesting question.
Yeah.
Uh, there are regulations for cellular therapies, and yes, FDA regulate some of those things. I believe that we need to have honest conversation, what it is, how it behaves, and what we also don't know. I am not certainly God. I spent 30 years in this, but I still have a lot of to learn. We have, however, a lot of different forces and different facets. The FDA feels that it needs to be maybe regulated because there are a lot of clinicians, a lot of clinics, they twist the language. They start selling this as a miracle. Uneducated customer there is a information asymmetry, then feels they got taken advantage of. Many times I see these, sometimes these horror stories that one patient saying, I went to Panama, I got a miracle cells and I am happy. And I am happy that it works for that. The problem is the same therapies you may go to Panama might not work. And then they believe because we have told them that it's a result of procedure, the outcome is not good and patient is disappointed. That's why I am here today to tell you that it is not a medicine. It is the body and total package. So if you want to have a consistent outcome, you need to look at the both sides.
Yes. So in your book, um, you have a concept that you mentioned. It says soil before signal. the idea that the biological environment matters more than the therapy itself. Can you walk us through that analogy, that your concept, soil before signal?
Absolutely. So, hold on. So I don't mess you up, so to speak. This soil as the soil, biological soil, is just analogy where I am trying to bring into attention that human body uh, and human systems interact similar, like when a gardener is trying to plant the seed. Let me use analogy that I use uh, quite often in uh, with my patients. Regenerative medicine is a little bit like a gardening. Gardener cannot force plant to grow simply by pulling on it. The growth happens when conditions are right: healthy soil, adequate sunlight, water, supportive environment. So if we take the same or regenerative therapy work in similar way, we are not forcing tissue to rebuild themselves. Instead, we provide signals, right? I am keeping talking about this because those signals guiding repair. And if your biologic environment, soil, is supportive, meaning if your metabolic energy is adequate, if your mechanical forces are appropriate, if you, as a physician, accomplish that inflammatory signaling is balanced, then your biologics, PRP, PRF cells, whatever you use, that environment will amplify the body-owned regenerative process. But if you skip this, or if those conditions are not present, same signal will have very little effect. So that's why I tell often, I use this analogy, soil before signal, that I believe that regenerative medicine is less about forcing tissue to change and more about communicating with a biological system that already govern repair. That's what the intelligence is. We are not smarter than body. We just believe that when I inject something, it will respond. No, it doesn't. I'm not God. The body decides.
Yes.
Does that
I
make
mean,
sense?
yeah, of course. Thank you. That was a perfect analogy. I think it's very easy to understand. And how do patients respond to that when you explain that to them? Do they respond well?
Yeah. Well, I think that this comes to another good question. We have to communicate with the patient because right now, if and that comes with the language, we
Hmm.
have to understand that we are trying to optimize their biological soil, if you will.
Yeah.
And also, we need to communicate to them that they are as important as a doctor. So, what they do outside of the clinic also matter. And I believe that communication create true partnership because now they understand and they don't feel like one of my pet peeves is that sometimes I have to wait. I tell patients we have to wait. And it's many times difficult conversation. Doc, I'm hurting. You are not doing anything. It looks like negligence. I was like, no, we are gonna optimize your body first, soil. We can manipulate. We have a lot of different tools dealing with your pain, but I am not going to inject signal into unprepared soil because I may get exactly opposite response, right? This is not putting screwing somebody. Those biologics are potent molecules with a multi-system effect, and it is not just injection. Just because I inject it, it's like I could give you a few drops of poison. It's just the drop, but it may kill you. So this is how I think about it. And I am big proponent that we should not focus our attention on signal itself, but we should look what is really making, what determines the outcome. And that's the soil.
Okay. So not focus on the sick. Okay. So more on the soil, the environment of the patient.
Well, don't
So
get me wrong, Oscar. I'm not saying that biologics are not important. It is, but not as we. If you talk to doctors 9 out of 10 times, they talk about what we inject, what growth factors contain, what technique we use it deliver, left hand, right hand, should we do navigation, ultrasound, this and that. And when they ask them, okay, but how about Mr. Smith's inflammatory condition? Who cares? Oh, did you check whether their mitochondria has enough, produce enough energy so the cells can really adapt? Oh, no idea. Okay. So we are focusing on one part because it's simpler, right? It's not easy to figure out somebody, you know, soil. I used advanced metabolomics. That was another learning thing for me as an orthopedist to analyze metabolic, you know, landscape of the body. But it's not only metabolism. It is
yeah.
about sunlight, sleep, and you name it.
Yeah, I mean, it goes back to, initially what you mentioned, that the injection is not the starting point. The starting point is the soil, right? The environment. Fix
Anybody
that
who
first.
anybody who use forgive me, anybody who tries to plant any seeds, whether you do gardening, and I'm sure that a lot of people understand that, very few people will come and say, I have a seed. I don't care how the soil is. I'll just drop the lawn, you know, grass seed on any unprepared. It'll be fine. Everybody will look like, man, the soil is dry. It's it's really depleted.
Yeah.
It's not gonna do. No, I have the best seed in this. I bought it for I don't know. It would look
Monsanto.
it would look uh I want to say idiotic, right? So, but we do this in medicine. I think that we need to step back and get a little bit away from procedures. I am orthopedist. We love shiny tools. We love to do with our hands. Hey, do you do navigation? Do you use this and that? Do you use AI? Body is smartest intelligence we have, and many things we don't even understand. So
Yeah.
first, we need to listen.
Yep. I
It
agree.
also helped me with my marriage. I listen my wife much more. No,
I agree. I agree with that. I mean, I at least the smart ones take that and apply it right to their personal
I
life
want
and be
the
better,
one
right?
smarter, but listen to her, and at least being active listener helps quite a bit.
I agree with you. I by building by doing these podcasts, I've actually improved my communication, become a better listener. So I am with, and even my relationship. You're 100% right. I agree with that. I do want to touch on a couple of points that you mentioned. Um, I've never done gardening myself, but my mother-in-law does it. And obviously, to set the soil, it's challenging. There's so many things that go into it. And then not only that, once it starts growing, you have to take care of it. You have to water it. Then you have to make sure that that's not contaminated with another, plant. Or then you have, maybe some like insects that are eating your plant. There's so many things that go
Let
into
me
it.
ask you a question. You just described that through experience and you gardening, you are taking into account a lot of different aspects. Other insects, do you need the water? Do I prepare this? Now, I think that we as a doctors, we should use same analogy to say, is my soil prepared? Not says I have only seeds. That's what I'm saying.
Good. That's a very good analogy. And I'm hoping someone, can take that and understand because it's so simple. Then one thing also, you mentioned that the 9 out of 10 physicians, when you talk to them, it's just about the injection. Why do you think, do you think they don't care or they're not educated? What do you think the problem is there?
No, I don't think that they are negligent or they don't care. No, no, no,
Hmm.
I don't think so. I think that they are in a system in echo chamber. It's just that's how we are being educated. We've been told that what do we do matters. more than what the body is. I think it's a little bit of hubris, a little bit, and maybe
Yeah.
ego. But we are trained to say, oh, this is a biologics, this treatment is better. And then we also start, um, we are talking to our colleagues and they are trained in the same thinking like we do. And now suddenly you come and start saying, no, maybe we should reconsider. Maybe what I believe is not correct. And it is a challenge, and especially every day. And then you have insurance and this and that. Sometimes you don't have enough time to sit down, step back, start thinking. And if you run the practice and you have to pay your bills, then you don't have time to philosophize about should I do this and that and other. But that's why my change came slowly. I have seen it, and I used to do surgery. And one of the things I always thought is I have to make sure that I know what I'm doing because my surgery, putting screws or implant, is irreversible. I cannot say, oops, sorry, it didn't work. And we all know that spine surgery is not exactly 100% outcomes. So this is a challenge. And quite honestly, I have now better results with my patients than I had in my surgical practice. They get rid of the pain. They are feeling better. They are back on their feet much faster. No cutting. It's cheaper for them and for everybody. I actually developed this concept. I call it heal yield. I believe that we should look at therapy as we look at financial yield. We should say how much biologic yield this intervention therapy will provide to the patient, because sometimes if all those systems are aligned, small investment, good sleep, good eating has a lot of return. But sometimes if it's all those systems are disorganized, a lot of activity will still have very little yield.
Yeah.
That's the whole, and the HEAL is acronym actually. It's called homeostasis, energy, activity, and longevity. So these are just practical ways. How can I measure that I'm making progress? Because we can philosophize or have a philosophical discussion about how we approach soil and stuff, but there are some practical steps that we will discuss if you want to.
Yeah. Yeah, sure, we can. So my next question was, which I think we can kind of dive into that. So you said that, you know, when do you know from your experience when the body is ready to heal or regenerate, right? Like what does the readiness look like and what blocks it?
Okay. Hmm. Let me just make a. What you mean when the patient, when I know the patient is ready
Is ready
for
to
that?
heal. Yes.
Okay. Um, so when first we have to start with evaluating where we are. In my clinical practice, I use advanced metabolomics. We take the droplet of blood. We measure about 180 parameters. We create a digital twin of the body. And then the digital twin, those 180 parameters, are placed into 14 domains: aging, mitochondria health, energy, hormonal status, cardiovascular, toxicity, et cetera, methylation profile. Now, when we look at those things, now I have um,
Good
some kind
idea.
of idea how the entire body looks like. The
Interesting.
second step is I have to figure out the sequence, because let's say body, we have a toxicity and I will sound a little bit like a functional medicine doctor now. Let's say we have a toxicity. A patient has didn't know as a toxicity. Golf players, my favorite subject. They day in, day out, professional golfers are on a golf course, which is treated with glyphosate. They are having a lot of health issues, although they play golf every day. Now, if you look at it and they have high oxidative stress may deplete your mitochondrial energy. You may have detox pathways altered. So you have to figure out what is the primary cause and what is the secondary stuff. Based on that, now you know what your soil may require. Now, the beauty of the people that I work with, we then put this biological digital twin into AI. They create AI where they handpick all the clinical studies that have been ever published. And then they put about 1,000 models to try to optimize this biological soil. Once this biological soil, we get about 78 pages report, what it needs to be suggested with all the metabolites and everything. So it takes him about an hour to sit down, go through the report, and prepare plan for optimization for my patient. First, I start talking about how to change the diet, the lifestyle, movement, etc., and maybe some supplements. This may go 2 weeks, 4 weeks, depending how bad it is. But they are coming to me, let's say, with a bad knee or backache. In the meantime, we deal with those symptoms, but I explain to them that first, if I will just inject biologics, I don't know what the outcome will be. And none of my patients come to me for injection. They all come what the injection would do to them, but they don't know all these nuances. So first is a conversation. Again, language matters. The second, we have to figure out what is the true problem. And I'm not looking at the knee only, I'm looking at the whole body, entire human being from systemic perspective. We optimize the body, then we inject, we send a signal, and then we send other signals like nutritional support, the rehab, and we manipulate this to guide the body to the outcome that I desire. How I know? Because I will tell patients, look, when I inject, let's say PRF, first 5 days, I will activate your immune system. You will feel tired and maybe even sore. It's normal. Do not fight it. Take it easy. If we need to communicate, otherwise they don't know what's going on and we will have a problem. So that's how I approach this. I hope that it makes some sense. I'm not confusing.
No, no, not at all. So is this you coherence is a word that you mention a lot. Is this what you
That
mean by coherence?
Yes, that's exactly it. Meaning that when I look at coherence, and forgive me that I am using this complicated word, okay, because that's how I refer to ability, body to operate in coordinated and I would call it mutually supportive way. And again, I'm coming back to this human organism is not collection of isolated parts, right? So if you are in coherence or coherent state, energy flows where is needed. Inflammatory signals resolve appropriately. Tissues adapt to mechanical stress. Nervous system permits normal movement. In other words, body is capable of responding to challenges in a flexible and organized way. And that's what I describe as a biological coherence. Hence,
Yeah.
when the coherence is present, healing becomes possible because systems responsible for repair are able to communicate and coordinate this. We are just kind of along to the right, we are there to guide it. But when coherence is lost, same system begin work across purposes. Let's say inflammation is remain chronically elevated, energy metabolism is becoming insufficient. Let's say your neural system sense there is a danger, so it restricts motion because it protects you. Then same treatment will have zero effect. And what that means, patient will then look at you and say, Dr. Talac, I don't understand. I am a failure. No, you did not fail. We just were not prepared. And uh, it happened to me too, but I just learned over the time to recognize the signals early and adjust. So the failure is not necessarily problem. It just, I have misunderstood how the body responds. So that's why I think one of the topics is that failure is just the information. We need to learn from it. This is not because if we believe that my injection is not sufficient, it's a problem. So once you begin to look at this from what I call regenerative intelligence perspective, the regenerative medicine become very predictable, less confusing, and patients are much happier because healing is a natural consequence rather than something that I have imposed from outside.
Yeah. So that brings up a great question here. So when you mentioned that when regenerative medicine does not happen, right? When regeneration, sorry, does not happen, you mentioned that it does not fail, right? So it has made an intelligent decision under constraints. What does that mean? Essentially, that it's like that it has made intelligent decision.
Yeah. So your body constantly, if we look at it, what I am now kind of preaching the signals,
Yeah.
if you accept that there is an intelligent system that is constantly evaluating the signals coming in and out, that system is making decisions. What is the best action next? And although we believe that healing, regeneration is advantageous, it might not be. If you, let's say, you have chronic inflammation, your body is metabolically messed, and you are asking body to heal, which is very metabolically expensive. It needs energy. The body says, no, this is not it right now. We are going to stabilize this and protect because that is. And a doctor is looking at it like, I don't understand. It doesn't work. What it usually happens, I call it what I call that I have these archetypes of failure that you can start seeing across that I see the doctors start thinking, oh, I have to increase intensity. I increase the dose. I get stronger drug. Instead of saying, wait, we have to figure out what's going on. Maybe we are not prepared. That's my message.
Interesting. And then it reminds me of one story that because we do I work with a couple of doctors that we train other providers that they want to integrate PRP. They want to learn regenerative medicine, and he told us he says a story frequently that it stuck with me to where he said he had a patient one time, and she said that the patient had gone to multiple orthopedic doctors, and they could not figure out what was wrong with her. And so he's like, okay, like he went through ultrasound and he couldn't find anything. And he's like, all right, before he did anything, he started asking her questions like, okay, so what do you do? Like, do you walk? Do you run? She's like, yes, I run every morning. I walk on the beach one way. And then I was like, okay, that's good. I'm like, every morning you do that? She's like, yes. Okay, well, what about, and then what happens like, and then what happens after? She's like, well, once I walk one way on the beach, but then when I walk back home, I take the sidewalk and I walk normal. So then he's like, wait, he's like, I think I know what happens. So what happens is that, the beach is in an angle. So after her walking, so many times, it's her hip, right, is sideways, right? And so, after a while, you're putting a lot of, weight on one side. So what happens is like, listen, I don't see anything wrong with you. I just think that you've been, walking one side. I'm like, I'm not going to inject you. I'm not going to do anything to you. I'm like, just do me a favor, walk the opposite way and then let your body adjust. And she's like, oh, what do I'm like, no, just do that. She went back and supposedly, I don't know, like about after a month, called and he's like, I feel better just because of that one, you know, one thing that she had to change in her morning walks.
He listens and go and ask. Yeah, it makes perfect sense. You know, our walk is a controlled fall. We evolve as a human being in gravitational field. And when you walk on a beach, believe it or not, when one of my mentors once asked me how much legs you can, as an orthopedist, to cut off before patients stop walking. It's semi tricky question because the answer is you can cut off all those lower extremities and patients still will be able to walk a little bit because they work on their pelvis because our engine is our spine. And we have lumbar spine that is bent rod. And if you bend, pre-bend rod, it's a mouthful, sideways, you create torque. And that's how we oscillate. And when you make a step forward, you end up on your outstretched lower extremity that is making little impulse. So that will bend your torso sideways, and that's why how we walk. If you walk on a beach, that impulse is much less because you're either that's uneven or your sand will absorb it. So you now have to complement it with muscles, so you get tired. And sometimes people will have a pain. So
Yeah.
once you listen and try to figure out what's going on instead of saying, I'm doing PRP, PRF, bone marrow transplant, whatever, uh, you have to figure out what's going on. I tell my colleagues when I did, you have to be a doctor. You have to figure out why. And many people, especially like in a spine world, we accepted this back pain is a diagnosis. It's not. It is a symptom. And there is another thing. I'm getting now old. When I was at Mayo Clinic, I went to Mayo Building and Dr. William Mayo wrote there that patients will always forgive you if treatment doesn't work, but they will never forget if you misdiagnose them. So you always better to figure out what's going on, and especially in a regenerative medicine, because it has such an aura that it works in everywhere. It's everywhere. You put PRP on LinkedIn, you go, everybody's writing there about everything. And so we need to a little bit step back, guide the patient, explain, use our language correctly, and also tell them what is possible, what is not. And one additional thing, I believe that patient should engage in conversation with the doctor, right? It is not, hey, doctor, my back hurts. Yes, we're going to do this, this, this. Okay. They should start feel comfortable to asking things like, doctor, what needs to happen in my body for this treatment to succeed? Or how do my daily habits, movement, metabolic health play a role in my outcome? Maybe not outcome, in my health.
Yeah.
Or what can I do to improve biological environment before and after procedure? Those should be questions. And that when these questions recognize that regeneration is not created by physician alone,
Yeah.
and that's why regenerative medicine is fundamentally collaborative.
Yeah. Do you think, I mean, those are, I mean, that would be amazing for patients to ask those types of questions, but do you think that the patient relationship, because of insurance, they have to like you mentioned, right? You would see so many patients when you were, when you were doing a lot of surgery, but that didn't allow you because you had to like see a lot. Do you think that how insurance and how the system is set up allows the doctors and the patients to have these long conversations?
Well, it's up to us, doctors.
You're right
We
about
have sold our farm. We are number one, there's a different conversation. We are here to protect our patients and conversation. At the end, they are paying customers. They don't care whether insurance pay us. They don't know many of the times what's happening. This is a different story. And I think that we all focus on insurance, how much insurance paid, we should focus what the customer gets, the results, right? We, many of them, we don't even want to, many of us doctors don't want to report results because it's complicated. Yes. So I think it is everybody's decision. I'm not saying it's difficult if you are on assembly line. If you have to see I used to see 70 patients a day. I have timer on my myself for 4 minutes conversation, and then 5 minutes it would do beep, and my nurse knew I have to get out. That was assembly line, and we changed. I don't think it's possible to do regenerative medicine in 4 minutes. It's just impossible because you have to sit down the patient, talk to them. You look at these, and everybody will have to decide. But I believe that patients, when they trust you, they will also be able to pay you. I'm not saying 100,000 for consult, but it is. I don't see many doctors to go hungry, and I'm not against making money and stuff. But I think we as a doctors have to take the power of the farm back. We need to protect patients and our farm. We have led others to interfere in the relationship and dictate us whether I will spend 15 minutes or 20 minutes with the patient and whatnot. Patients are not coming for visits. They have problems. And that's why we have the medicine where we are, because especially since COVID, we have lost trust.
Yes, we have, especially after COVID. There was an article that I read that I think patient trust declined from, I think, like 37, 40%, something like that, to like 70% or something like that after COVID.
I think that they deserve that we speak to them. I think this is up to every physician. I understand it's not easy, but it is still doable.
I agree with you 100%. So I know you said that there's 6 recurring archetypes of regenerative failure. Did we touch on that a little bit?
We can, if you,
Yeah. I mean, up to you if you have time. I don't have anything scheduled. Up to you.
I have time. I don't want to get overtimes.
No, no, there's no time. It's fine.
Okay.
So I would like to go over the 6 recurring archetypes of regenerative failure and which pattern do you see most often in clinical practice?
Okay. So in my books, I describe these what I call 6 archetypes of failure. So one of the things that I have observed for years, that when regenerative medicine fails, it really rarely fails randomly. Uh, I I had my enough of my failures. So failure tend to follow a recognizable pattern. And unfortunately, these patterns repeat across clinics or discipline or even across technologies. Because when you start looking for these, what I call the red flags, you realize that issue is usually not clinician, that clinicians are careless or the tools themselves are ineffective. More often than not, this biological system is behaving predictably because broader context has not been interpreted correctly, right? I described these six recurring clinical archetypes. E- each of them reflects a specific, I should say, misalignment between intervention, biological environment, and timing of the intervention. So one of the most common, I call it context-free intervention. This is a situation that intervention itself is technically sound, procedure is performed correctly, biological preparation is appropriate, uh, therapeutic concept is reasonable, meaning on paper, everything should work. But intervention is introduced in a system that has not been prepared. And what we have discussed so far, you can now predict what happened. Nothing. In this context, regenerative signals enters the biological environment. They cannot interpret it properly. And although doctor and patient thinks the intervention should work, but it does not. And not because therapy is ineffective. It is because organism is still operating under constraints. Sorry that I use these under these adverse adverse circumstances, constraints.
Words.
Another another archetype I often see is what I call a protocol prison. Here is the problem, not biology of the patient, but rigidity of clinical approach. We have protocols and many doctors follow them faithfully because, let's face it, they represent standardized knowledge. But when patient biology does not respond as expected, we sometimes fall into that protocol is simply repeated or escalated. We don't step back and reconsider what's going on. So I am not against protocols. They are very useful tools, but they are not biological truth. And they cannot be replacing thinking and judgment. That's up to the doctor. So when the protocols replace clinical judgment, care can become rigid. And then clinician begins treating the protocol rather than interpreting the signals coming from the patient system. So if you look at these two, not to go into too many details, both these archetypes reflect same underlying issue. We are focusing on intervention while overlooking the system that must respond to it. But once you recognize these patterns, at least in my opinion,
Yeah.
failure stops being mysterious. It becomes pretty informative. And I think that each of these archetypes just reveals something about constraints under which the organism is operating or assumptions guiding our decisions. Okay. So, in this sense, I look at the failure as the diagnostic rather than discouraging, you know? So, and I believe that as you, as a physician, and I'm sure that those who listen to me will agree that the real skill in any medical specialty is not avoiding failure. We can do that. But learning to recognize these patterns early, interpret what biological system is telling us, and perhaps respond with adaptation rather than escalation, right? And that ability, I believe, to step back from procedure and understand the system is what I describe as a decision intelligence in medical care.
Yeah. Well, I believe that failure, not only in medical, like in business, right? If you fail, continue, right? Get up, learn. What did you do wrong? What happened?
Some people didn't do anything wrong.
Yeah, yeah, correct, right? Look at what happened, adjust, and continue, right? One of those patterns is what you call the escalation spiral. Did you finish, by the way, the 6 archetypes? I think you only covered 2.
No, I think that that's we have more of these, but it's pretty much same.
Okay.
So yeah, th- these two, what I call protocol prison and context free, meaning nobody cares about uh, body. These are most common, and there are a few others, but
Okay, these are the biggest ones. So in one of those patterns you call escalation spiral. And when treatment doesn't work, the instinct is to do more, stronger, faster. But sometimes you said that, why does that often make things worse? I'm not claiming that you said things make worse. I'm just saying that sometimes it makes things worse. And going back to my experience before I kind of want you to go in, is that same thing I see it. I mean, I'm not a doctor or clinician, but what I see is like, okay, if PRP isn't working, inject more platelets, inject a higher dose, right? But you're saying that you don't have to do more, right? So what do you mean by that?
yeah. So again, I call it escalation spiral. And it's something that I believe many physicians will recognize, although we may not always describe it explicitly. So, what I mean by that is when the treatment does not produce expected result, then nature instinct, both for the doctor and for the patient, I believe, is to increase intensity of intervention. We might repeat procedure, add another therapy, move to stronger medication, okay? Or we go to surgery which is a aggressive structural solution, right? So this response is understandable. But in many areas of medicine, increased strength of intervention may produce stronger physiological effect, but it doesn't mean that patient will get better. So because we are now dealing with a adaptive system that might not appreciate how we are intensifying things. We are not trying to force it. And again, if underlying biologic environment is not prepared to support repair, and I spoke a little bit about inflammation is dysregulated, cellular energy insufficient, and so on, then applying stronger signal does not necessarily improve outcome. Actually, in some cases, it may actually add additional stress to a system that is already struggling to adapt. So if you are trying to force issue, organism may respond by increasing protective mechanism rather than regenerating one. For example, nervous system may maintain or intensify protective movement patterns. If you are forcing immune system, that signaling may just go to defensive state. So now you are, instead of promoting adaptation and healing, you are just pushing body into more resistant status, right? So when regeneration does not occur, the problem is rarely the signal is too weak. It's really not the problem. More often is that the biological condition necessary for responding to that signal are not present, or there is some constraint. Forgive me for those words.
No, it's okay.
Escalating intervention without addressing those conditions can therefore push systems further away from state required for repair, right? So I believe that more productive approach is often to pause and ask different questions. What constraints are preventing the organism from responding? Do I need to address those constraints? Because once those constraints begin to resolve, again, inflammation become balanced, energy improve. We address mechanical environment. Then same regenerative signal that previously produced no or little effect may suddenly become meaningful. In other words, healing often requires better condition, not stronger with, right? And that's why I believe that we need to shift our thinking from escalation to understanding a system. And that's what I believe is the central principle of the regenerative intelligence framework.
Nice. Okay. Is one of the biggest mistakes in regenerative medicine that we judge success too early or before the body has had time to organize a real adaptive response?
Yeah, many times,
Hmm.
uh, I see that we just simply are impatient. We have, and it's not that I would love to inject somebody and they walk out my office, but it's not how biology works. It has their own pacing, so to speak. So many times we need to, again, this is about communication and assessment and adapting what the body is telling you, right? So um, if we are using logical pharmacology, when drug works, effect usually visible quick because drugs is forcing biological change. Okay. But if we use biologics, they behave differently. Again, as I told you, they do not force change. They are sending signal, right?
Yes.
And it takes time. And before regeneration can occur, body often has to recognize several layers of biology. They have to reorganize all this stuff. So what we are really watching is not a linear treatment effect, but system adapting to new set of signals. That's adaptive process unfolding in front of your eyes. It is not, hey, we want to have 24 hours. And yes, it may happen that if you judge the outcome too early or misinterpret the trajectory, you may say, oh, let's move to strengthening where the body was not ready. And you will have a little setback. But again, once you recognize that, oops, we are not going where I want to, we need to adjust, that's perfectly okay. It's not one and done. That's another pet peeve I have, is the fallacy of single procedure. There are no silver bullets. This is, I can suppress symptoms, but it's not my goal. My goal is durable, optimal healing or regeneration, so the body is now able to withstand what life throws at it.
That I often see on LinkedIn. You made a good point there, to where when I see a couple of physicians talk about, let's say, for example, why it would be ideal for a doctor to inject one single shot of, let's say, 10 billion platelets and done, one and done. Instead, there's a couple of studies that I've seen that a cumulative dose, right? To where, like, you maybe inject 3.5 billion, but spread it out between 2 to 4 weeks, right? So now that you mentioned that, it makes sense, right? Like, why would you, if I were a doctor, I would want my patient to have a good relationship with him, come back in 2 weeks or 4 weeks, but I understand the other side of the coin, to where I'd rather just have them come in, one injection, and be done. Like, what's your take on
I think this is exactly opposite spectrum what I am proposing,
that?
because we don't take, if you have a headache or you have infection, you don't take all antibiotics in one dose because you just want to be done. It's not gonna have the same effect. But it comes to that we think that more is better, stronger will get faster. This is not how it works. These biologics, and I'm sorry I'm repeating myself over and over, are signals, are not drugs. We are not forcing anything. You just need to accept that the body needs to work through the stuff, and you have to listen and adjust with those signals. Same what we do with a drug. So I'm not saying that it's black and white. You are not gonna give patient all the antibiotics for 7 days in one dose. You try to intensify treatment based on some logic, right? But I think this type of thinking, let's put one dose strong, it's mechanical thinking. We want to just have a unit, shot, teaching next, and just run through a mill of people, because the time is becoming the most valuable. This type of practitioner, if you will, I don't want to say the physician or whatnot, is just trying to maximize the time and move through a lot of patients, and it's become an assembly line. I don't think that that's the best scenario, and it will create a lot of problems.
Yeah, no, that's a good way to put it. What I've seen is like, oh, and now I'm answering my own question. But oh, if I only do, let's say, a lower dose, then they might not come back. Well, then if that happens, then you haven't established a good patient relationship with that patient, if you're afraid that they won't come back.
I don't have that problem.
Yeah.
Forgive me, I don't know what's happening here. That's just, but I don't have the problem. They don't come back because I start conversation first. I explain patient. Sometimes the consult is 2 hours just to go over what are expected outcomes, how we gonna do this, and most importantly, I call it the patient to be participant needs to be engaged. But
Okay.
before we are engaged, it has to be enrolled. Now there is information asymmetry. They come, they read all kind of stuff. They believe uh, we need to first to kind of address the information asymmetry. This is how I approach patients. When I start talking to them, I tell them, look, we are now, figuratively speaking, standing at the one edge of a big cliff, and we wanna get across. Before we get across, we have to agree that we are gonna build a bridge or airplane. Both of those things will get us across, but they are completely different processes. So I start conversation. I start telling them there is no fix, there is this and that and other. We have to educate patient first, Then they have to make decision whether they are willing and able to participate. And it's not gonna be one single shot. Many of my patients come and say, "How much the shot cost?" And I would just say, "I'm sorry, I don't do shots. I first have to figure out what's going on with you. I never talked to you." And then I look at patient mouth for the oral microbiome. I talk about how they sleep, what stress them out. It used to be that when I start talking to these people, let's say, especially women, would start crying. I felt so uncomfortable. I was not used to going into emotional stuff. That was, to me, it was easy. I walk in, I saw MRI. "Hi, I'm Dr. Talac. I know what's your problem. You need surgery. Would you be willing to do so? Or will insurance pay for it?" "Yes." "Okay, Maria will put you on schedule. Was pleasure to seeing you." Oh, I was assembly line glorified carpenter. This is not Robert Talac version 2.0. This, you cannot, in my opinion, practice regenerative medicine like this, because it will catch up with you when people will start coming to you. If you start doing just becoming a proceduralist or technician, there will be substantial portion of patients, they will be unhappy. They will not know what's going on. And if you didn't explain to them that we have to prepare the body, your outcome will be inconsistent. And in regenerative medicine right now, a lot of those therapies are not covered by insurance. So patients are paying and they expect outcome. And therefore, with every patient, every treatment, you are not only giving them treatment, you are bringing your reputation. And that's not good, because those people talk and we have social media and all this stuff. So, uh, I truly believe that we need to be professionals. And there's many facets. We can talk about timing, we can talk about biologics and stuff. This is a real deal. I think this is the future of the medical field.
Amazing. Wow. Uh, I agree with you 100% there. Do you think that patients can feel worse before they get better during regenerative care? Kind of like that saying, the calm before. Well, actually, no, it's the opposite, right? So they start feeling worse before they start getting better. Um,
Yeah,
how how what
yeah,
happens biologically?
because because we use many of those biologics are actually modifying or altering immune response. We already have innate ability to heal. We just manipulate it. So we talk PRP. Let's talk about PRF a little bit so people don't feel I'm attacking PRP. When we inject PRF or any platelet derived biologics, we are sending signal to body that there was injury, bleeding, and this tissue needs to be repaired. There was no injury. It's a fake news, so to speak. But your immune system will respond. So the first 5 days, there is inflammatory reaction. And depending on the dose, the patient may feel sore a little bit. They may feel tired, like they have a flu. And if you do not communicate patient, "Hey, this may come," what they will do, they will pop 6 Alefs and kill entire reaction, and your treatment will go down the drain. If you haven't talked to the patient about this part of thing, then you will not know why it doesn't work or why we have this. What they do at home is as important what you do in the office. So yes, they may get worse. You need to talk to them. It is also particularly challenging with these PRP, PRFs, because when we use numbing medicine for injection, we sometimes numb the painful area. So they feel right after like $1,000,000. Some of the patient will go and try to catch up on life because suddenly they don't have a pain. Their garden needed to fix for 6 months. They go back and suddenly they will have tremendous amount of pain. They will be scared. "Oh my God, what happened? Did I mess it up?" And stuff. That's why I semi-jokingly tell people there are two problems in medicine: acute bleeding, because you may die, and lack of communication. If you do not communicate, patient goes to see another doctor. The doctor see, oh my God, you hurt, you have temperature a little bit up. They may not understand what the biologics did. They put you on steroid, or they give you antibiotics, or do other stuff. We unfortunately have medicine in silos, but patients don't perceive the problem in silos. They have continuous problem, but sometimes they go to ER or urgent care. Yes, so short answer is yes, they can get worse, but it is manageable if you tell them what's going on.
Of course, because they know what to expect.
Women go to have a labor because they communicate. Otherwise, none of us men would deliver any baby because we would not suffer through this, right? But they communicate, they know what it entails, and they still go and prevail. If you do not communicate and you are shocked, then you have a challenge. I truly believe that this partnership that regenerative medicine forces us into is a good thing because the patient understand I cannot, a doctor is not gonna win alone. I cannot be passive recipient, and it's also put some responsibility on them. And yes, there are some of us or some of the patients, they would tell me, doctor, I'm not gonna change. Then it's your decision whether you will institute the treatment because you know that you will probably fail, not because the therapy is bad or you are negligent. It's like a team sport. If we play soccer and one guy does not cooperate with other, we're going to get beaten.
Yes. I mean, I'm a big believer to where communication is key in any relationship, any partnership, right? I mean, if you communicate well with the other person, the other partner, then, processes, you understand, it works efficiently, right? Um, for a patient that has been told they need a regenerative procedure, what questions should they be asking their doctor that they're probably not asking right now?
Yeah, I touched a little bit on it, but I think that, as I said, that in this in this regenerative medicine field, I think that the patient role is much more important than, let's say, in any other. Let's say if you do surgery, they, of course, they participate, but mechanical procedure is mechanical procedure, right? So I think that they should, number one, patient should start conversation. Now I tell my patients and others, and you have to understand you are coming to the doctor's office. Good doctors are busy. Be prepared. Time is of essence. Do not, you want to interrogate your doctor, not to tell doctor what your cousin told you. A, he doesn't care or she, and B, it's wasting valuable time.
Hmm.
So I tell my patients, if you go to any doctor, ask one thing, make all things written. And they try to make 3 sentences, what is the problem? And then you have only one question. Why am I hurting, doctor? All right. What is going on? That's the only question. There is no reason to ask about treatments if we don't know what's going on. If doctor will skip, let's say you have a back pain, you need to ask doctor, why am I hurting? And then be quiet. Listen to the doctor. Don't tell him that your cousin has also bulging disc and had this surgery and stuff. It's not going to help you. At the end, you came to listen what doctor has to say. Once we know what's going on, then second question is, what can we do about it? And again, and listen, if you now you can record the doctor, you can have a note, you can have what he says, you can let uh, listen to it. What I would not do to go to ChatGPT and try to get a second opinion on ChatGPT. ChatGPT is not gonna treat you, and there are nuances that you may not know. If your doctor will not spend enough time with you, it is a first red flag because this is long run. This is true partnership. This is not command and control model. That's why I tell my patients, are you willing and able to work with me? I really spend a lot of time on this because if the patient is busy, will not change, we're not going to have a good outcome. And I am very, very straight and very direct about this. So when this dialogue happens, I believe the patient is no longer just receiving treatment. They become active participant in creating condition in which this regeneration become possible. And I believe that this partnership often turns out to be one of the most important factors in achieving durable results because they are now engaged. They care. They know. They call me, hey, I am doing this. This is okay. I stopped drinking. I do this. Now you see that change.
Yeah.
And I
Now,
use in my in that book, if anybody is interested, I use a relatively simple strategy. I describe three problems and job needs to be done and where we are going. And I also explain the patient explicitly how they will know that it's working because they will have doubts. I sometimes jokingly says when I do laundry, I follow protocol that my wife had. But if it doesn't know exactly what she said, I start thinking, oh my God, I'm messing it up. It's not working. And then I start changing programs because I think I'm smarter. Usually it ends up worse. Give the patient your cell phone number or somebody in your office nurse who is able to answer questions. 5 minutes off on the phone will save you a lot of time. And I know that many doctors know this, but in this regenerative field, it is that much more important because if the patient is 3 days not sleeping because they have demons, it will mess up whole treatment. I tell them, if you have a problem, I want to know it right away. I don't want you to have a 3 sleepless nights or the going to ER or anything because this will affect outcome.
yeah. Well, I wish many doctors thought the way you do, right? And how they explain it to patients to where like this is a partnership, right? I think it's also the system, to where do what I'm told and, an ego thing, like what we mentioned earlier.
But
You
we
know,
are still, we are still in, we have free will, at least, I believe that we have free will to decide how you want to practice medicine. And again, that's why I think a lot of these internal soul searching conversation needs to precede of change. This is not new gadget that will make you more money. This is a more precise medicine. It's rewarding, but it's a double-edged sword. It can really make you frustrating because now you have to synthesize much more information. I was much happier when sometimes professionally, when I look at the x-ray and say broken, needs screws, good. Although it takes 16 years to learn how to put screws in somebody back, and it's not easy. Still, it's much easier than to try to figure out all these layers of metabolism, movement, neurologic, in the pathways, etc. But everybody has the free choice.
I agree. But it all goes back to the mindset. They need to be willingly to unlearn and change their mindset on what, you know, they
Change is
they
always challenging, but still doable.
100%. So I believe that this concludes the questions for episode one. And for those of you guys that are watching, we do have two other episodes, at least for this series. I'm sure Dr. Talek and I will have plenty of more other conversations and other things that we will discuss. But Dr. Talek, do you mind probably giving us like a little bit an overview of the next two episodes? So the next one is regenerative medicine has a thinking problem, not a technology problem. Can you just, like a minute or two just to kind of what that is, because I think, to include this will help us, be like, oh wow, I want to, join the next conversation.
Yeah. So next, that's another one of the thing. I believe that regenerative medicine has not. We have a lot of technologies, but we have not been able to define a coherent, meaningful system, how to use them or principles. We all discuss this and that and other. We discuss syringes and biologics and PRP and PRFs and bone marrow and stem cells and exosomes, and off you go. We are producing a lot of noise. Uh, we need to, again, create the platform, not the procedures, platform where we will start systematically think how we approach this, same like in the traditional medicine. So the next episode, if you will, I will talk about things like the fallacy of wear and tear, where we tell people, especially in orthopedics, that joints wear and organs will get old, spine will deteriorate, because it implies this is inevitable. Yes, we get old, but it doesn't work that way. Actually, a lot of these changes that we see has our normal adaptation processes that body just decided to do because environment we put the body into. So we're gonna discuss this type of thing, how I think about human body, how I think about regenerative medicine and healing, etc. And we will touch now a little more on signals, meaning uh, we can talk about biologics. You have asked me about stem cells. I truly believe that there are no true stem cells in an adult body, at least in a way that we can transplant mechanically cells from bone marrow or from fat into the knee, spine, and stuff, and those cells will then transform in a new cartilage. It actually has been disproven. That hypothesis has been debunked. These cells will have effect, but there are much more, it's much more complicated than we just make it sound, right? It does work. We have some effects, but there are also some things that we are not talking about, meaning we mean doctors. And I think that for whoever is interested to deep dive into those issues with me, I'll be happy to answer questions. I have, as I told you, I have been semi inspired by you. I spend a lot of time in this uh, medical field, but I never actually exposed myself into conversation with the general public with these answer questions. But I believe that we need to come and start discussing stuff, because otherwise the space will be filled what I call by YouTube doctors, and then there will be a lot of misinformation. We don't need to fight misinformation by protecting it. We just need to get additional information and let the people to decide and answer question. That's why I hope that I was not confusing you and your audience. Just simple messages: the body or biological soil, that's what drives the outcome. Signals help, but without the biological soil, forgive me, I don't have any other better term, we will not have a consistent outcome. And unfortunately, we have very little conversation about how we optimize the biological soil, uh, or we will divide the field that we have, let's say, functional medicine, nutritionists, and other doctors. They take care of it, but unfortunately, they treat context as a support, not as the decisive feature, right? We hear these stories. Good sleep helps. Nutrition is also good, or you need to decrease stress. but that implies that it is supportive. It should be, if you don't have a good nutrition, you are not going to be healing. And it doesn't matter what I inject into you, you are not going to have a good outcome. That's completely different conversation. But this, it's not a prevailing uh, prevailing talk, or we don't have that type of conversation. So that would be the second piece. Third piece is one of my pet peeves, because I spend a lot of time in research. Everybody asks me, doctor, where are randomized controlled trials about biologics? And I believe that randomized controlled trials are not a good tool for generating knowledge. I wrote actually third book about this, how we should generate knowledge and prevent noise, right? Because randomized controlled trials where these developed, or the tool was developed to look at procedures or interventions across average population. But when you average population, you will lose that variability, and the information is at the best incomplete. So you read one paper, oh, there is a good outcome. You read another paper, same treatment, oh, no outcome. Oh, this is this. So when you read 5 papers, you actually do not know more. You are just more confused.
It's true. It's true. And
And that's the problem. And our answer is, again, like escalation. We say, oh, we need more robust randomized trial, right?
yeah,
When I don't understand Spanish, start yelling at me doesn't help me understand more.
that's true. And then, what I had a podcast with a researcher like about a month ago, and he mentioned about a randomized controlled trial, and he made a good point which stuck with me. And he said that and I'll add a little bit to that, when you're seeing patients in your office, that's a different setting, okay, versus having a trial, because think about it, they're subjects, right? So like their way of thinking, the way they are, coming into either your clinical practice to see you one-on-one privately, versus being a subject with hundreds of other patients, is a total different mindset. So what's happening internally biologically, I was like, that makes total sense, right? Like I never thought about it like that, and I don't know if that will make a huge impact on their therapy.
Yeah. And you're right. So again, not to this is not advertisement, but I spent wrote an entire book on this. That I believe that one of the problem with a current status of knowledge is that most research in regenerative medicine is still structured around procedural mindset. Typical research question looks like this: does PRP intervention regenerate knee cartilage? Or does this biological product improve outcomes compared to another treatment? Those questions assume that regeneration is primarily a property of intervention itself. As I've been arguing today for almost 2 hours, that biology rarely works that way. Regeneration is not a fixed capability of the product or procedure. It's emergent process that it derives from multiple biological systems. And when these systems become coordinated in a particular environment, we see outcome. So if we accept that biologics are signals, not intervention, then if we ask research questions that isolate signal from biological context, the what we then we should not be surprised that results appear inconsistent. As I told you, one study shows benefit, another minimal effect, another shows mixed outcomes. So from traditional perspective, this looks like contradictory evidence.
Yeah.
But if you look at it, or how I look at it, it just reflects different biological environment in which the signal was applied. But nobody is actually discussing it. So problem is not that regenerative medicine lacks data. The problem is that we have been asking questions that regeneration or that if that like the regeneration would be a product rather than process. So in my book, I suggested slightly different approach. Instead of asking only whether treatment works, I ask questions about condition under which regeneration process emerges. And then what biological states allow tissue to respond to regenerative signals? What constraints prevent that response? How movement, metabolism, inflammation, and let's say neural regulation influence those outcomes? When you start asking these questions, the data we already have makes much more sense. Okay. So, and again, I am not trying to criticize only existing research. I am just saying that if regenerative medicine should to mature as a field, we may need to shift from asking intervention-centered question to system-centered question. And it's a simple reason, because regeneration is rarely a result of single action. It's a consequence, right? So I believe that we should start stepping back again. But I am surprised when sometimes people say, oh, randomized control trial is the best tool. For what? Right? You are not going to pick up your strawberries with a hand grenade. It will be very efficient, but you will, you will not be having a lot of success. So I believe that also we need to, as a field, look how we generate knowledge, and it has to be in layers. Okay, I don't believe that if you that you can have what I call the one verdict trial. If I, 2 more minutes, let me a little bit
No,
unpack
go
it.
ahead. Go. I'm not. You're good.
I believe that there needs to be new research architecture. I call it 4-layer, and because regeneration is not a simple event. So again, what I call it, the traditional research is built around, I coined this term, single verdict trial. Study asks binary question. Does therapy works or not? And the study is aiming to produce definitive answer. That structure might well work if we are comparing screws against this and that. But regenerative therapies do not behave that way. And that's why, because we are introducing signals into complex biological system, and response depends on the state of the system, we need to reflect this in our research. So I proposed that in first layer is a biological readiness. So at this level, research question is not about therapy at all. We should ask whether biological environment of tissue is capable of supporting regeneration. And this will include factors like inflammation, metabolic energy, vascular support, neural regulation, mechanical stability, and so on. If those conditions are not present, system may not interpret the regeneration signal constructively. So that will be my first layer. The second layer examines signal itself. Here we can study biological properties of regenerative intervention. Is PRP truly autologous? I just wrote today about this. Okay. It is important that we understand what signal we deliver, how those signals interact with cells, what pathways they influence. This layer help us to understand language of therapy, what language the therapy is speaking to biological system. The third layer will be signal environment interaction. So this is where I would start asking under what condition this signal produces stable and adaptable response. Instead of asking whether therapy works universally, we should examine how different biological environments influence the outcome. And
Wow.
of course,
Amazing.
fourth layer is clinical integration. Only at this stage, once we have all these questions kind of figured out, we can start asking kind of questions that are typical for clinical trials. How therapy performs in practice, how durable results are, which patient population benefit most. And I truly believe the sequence matter too, because each layer answers different type of question. If I jump directly to final layer, testing therapy in heterogeneous clinical population. I have no understanding about biological readiness of the system or nature of the signal, then results will often appear inconsistent. And then if I say, no, we need to have more, we have 17 clinical trials, and it's a more and more noise. So the some patients respond, others do not. Field then concludes that therapy itself is unreliable. But in reality, what we are seeing is interaction of signal with many different biological environments. So that's why I believe that purpose of this 4-layer architecture is to move regenerative research away from search for single verdict towards like deeper understanding how living system interpret these regeneration signals. And when those layers are studied in proper sequence, suddenly the variability that once look at like this is confusion becomes the map of biological condition under which regeneration becomes possible. And I believe that that shift from seeking verdict to understanding is really the essence of research philosophy behind regenerative intelligence. So we can talk about third layer, how we produce knowledge, because this is the humongous field. I spent at least 2 decades, more like 3 in this. So I can talk 3 hours about every single piece of it, and we can deep dive. And for those who have a lot of questions, that might be good journey. I'll be happy to share. I don't know it all, but at least this is opportunity to maybe start asking questions. I ask different questions. I can inject anything almost anywhere. My kids make fun of me that I can put patient eye on their butt and it will blink. It doesn't matter that I should do it. I try to be, I try not to be only glorified carpenter. Uh, I, I have still some struggles. Who now am I? Am I a healer? Am I a regenerative medicine specialist? It doesn't matter. That's just the label. What I'm trying to understand language of our body and communicate and manipulate the body. So the process that is much more intelligent than I am can lead to desired outcome. And I have now tons of patients are proved that it is possible. I just sometimes feel that I don't do a whole lot of things. I just little navigate and they heal by himself.
Well, you're setting up the soil for success.
Yeah. Well, that's
Yeah.
cool. And then I'll become a gardener.
Amazing, amazing, amazing information. So much value. Amazing. Total mind shift. Dr.
Well,
Talek, I appreciate.
I didn't bore you to death. And
No,
I'll be happy to join you and your audience in near future if you will have me.
no, of course I would love to have you. And I think, we will essentially do the next two podcasts. And I think that I would love to do also the 4-layer of regeneration of what to of how a research study should. I think that that alone right there is just a full conversation. And I think, you know, proposing that and saying, putting that out there would be ideal because what you mentioned, I had another podcast with another scientist, and he said similar things of what you're saying, like that our RCT trials are flawed. And I'm just kind of connecting the dots, and I was like, this is great. Like, okay, you're saying that, he's saying that, and it's something I think that should be discussed.
I I agree. I think we should talk. There is not to attack things. We just want to learn and communicate.
Dr. Talek, is there any final words that you would like to say? I know we've gone for 2 hours.
I appreciate you having me. Again, I hope that it was not too boring. I am obviously passionate about this, so I can talk about this for hours. Uh, Thank you for having me, and I look forward to talking to you in near future if you have me.
Yes, for sure. Well, you guys have a beautiful day, and I'm looking forward to seeing you guys on the next episodes 2 and 3. Talk to you guys later. Adios.
Thank you very much. Bye.